Welcome, everyone. My name is Haley Buckner, and I'm the Professional Relations Manager at Elevate Oral Care. Thank you for joining us this evening. Before we start, let me cover a few housekeeping notes. For those of you remaining online past 50 minutes, your CE certificate will be automatically emailed within a couple hours of the completion of this talk. So be sure to check your spam folder if you can't find it. Also, be sure to visit the GoToWebinar control panel on your screen, and under the handout section, you can find a copy of the D1355 ADA Guide to Reporting Caries Preventive Medicament Application, which Dr. Horst will go into more detail on during the presentation, and there's another handout there as well. You are all muted, so don't worry about any background noise, and we will have time at the end for questions. Just submit your questions on your webinar dashboard. My colleague Steve Pardue will track questions throughout the talk. Throughout 2020, last year, we held a series of free live continuing education webinars on topics aimed at preparing offices for the expected changes to patient care due to COVID-19. Each of these webinars were recorded and are available with free self-instruction CE at the web address that you see on the screen, the elevateoralcare.com/elevatingcare. Be sure to bookmark that page and return often to see what's new. We're currently putting together our 2021 free live CE calendar, so feel free to suggest topics at info@elevateoralcare.com. We're honored tonight to host Dr. Jeremy Horst, a recognized expert in the use of silver diamine fluoride, having co-authored the first product protocols and several papers on its use. A recent ADA Health Policy Institute survey found that more than 25% of offices are observing an increase in the incidence of caries in their patient base since the pandemic start. We recently heard the term COVIDs used to describe what offices are observing. Many of you are familiar with the off-label use of silver diamine fluoride to arrest caries. Tonight, Dr. Horst will describe the primary preventive use of silver diamine fluoride to protect high-risk sites from ever-developing carious lesions. A new code, D1355, Caries Preventive Medicament Application, which is a per-tooth code, became effective this year on January 1st for this growing use of silver diamine fluoride. A little bit about our speaker, Dr. Jeremy Horst. He is the Director of Clinical Innovation at DentaQuest and holds affiliations with the University of Washington and UC San Francisco. As a practicing pediatric dentist, biochemist, and educator, he is known for investigating the strengths and limitations of silver fluoride therapy and helping to develop smart fillings. His mission is to reduce suffering from tooth decay by driving the development of better treatments and preventives to stop dental caries and thereby create an easy relationship to dentistry for all. Dr. Horst, the floor is yours.
Thank you so much, Haley, and thank you, Elevate, for making this happen. We reached out to each other a while back when the 1355 code, when it was realized that it was going to happen, and we agreed that it was really important to get everybody together to talk about how this can be used, in what patients, what's the mechanisms, what medications or medicaments can be considered, and so here we are. It's a dream come true, and it's been a long time coming, as you'll see. So I have moved, and I'm no longer with UCSF primarily, or in private practice primarily. I'm still associated with those things and doing those things, but just a little pitch for me and my group. As you can see in this picture, I look a lot younger. It was taken 7 years ago, before kids, before SDF. Anyway, I am at DentaQuest now, and so just pitch for my role there. If you are an innovator, if you are trying to change the oral health system, if you are trying to use research development, inventions, products, technology to do that, give me a holler. Especially if you have a low-cost caries compound, as in the next silver diamine fluoride, or a salivary diagnostic, contact me soon, because we are an impact investment group, and we are trying to help you build the future. So that's enough about that. That said, even though I am at DentaQuest now, what I'm going to talk about tonight is my own thoughts, my own views, and not necessarily those of DentaQuest or Elevate. Disclosure side, I am a full-time employee of DentaQuest now. I've had funding from all these organizations, and Everybody has biases. So I am the product of my environments and experiences. And so please take anything I say with a grain of salt. And if all you do is find a seed of an idea to go pursue looking at the data yourself, then we win. This is the outline for the rest of our time together. So again, this is really focused on D1355, on figuring out what's about, but then that first line says 1354. What are you talking about? Well, they're connected, and I hope to share why I think that is. We'll talk about what the new code is, how it really works, what the mechanisms are, what are the indications, where would you use this code, in terms of patients, risks, anatomical structures, and then what's the parts list, which we'll dive into. With that said, I do want to thank everybody. There were a lot of people signed up to come tonight. There's looks like there's about 650 folks with us. It's just a huge honor. Seriously, it's just such a huge honor that you're spending your time with us tonight. Thank you. I hope to remain being useful for you. I hope you guys can all of you speakers, all of you thought leaders that are on here tonight, please, please, please use my slides. Just like we put the slideshow together for Silver Diamine Fluoride for 1354, 6 years ago, 7 years ago. This is it for 1355. This is free for anybody to use. We'll tell you how later. Okay, so here we go. This is talking about 1354. So leading up to what we're talking about today. So this, according to the IBM Watson Medicaid database, the DentaQuest partnership for oral health advancement has a pretty slick webpage interface that you can find to interface with these data. That's going to be going through a big public launch that's already live. Don't tell anybody. You can find data like 1354 usage, which I did, and I plotted it out for you here from 2016, 17, 18, 19. We don't have 2020 data yet anywhere in a big public database like this, but there's a reason for me telling you this. This is broken down by age group. The orange is 0 to 5. This is on a linear scale. So you can see that, people think about 1354, about silver diamine fluoride caries arrest for very young kids, but that's about half of the use total, almost exactly. And it's increased dramatically. This is the beginning of the hockey stick. I guarantee when you see 2020, it's going to be way high because everybody's hands were tied behind their back with regard to drills, and so lots and lots and lots of people started using it. But the other ages got it too. And so I'm going to plot this same data using a logarithmic scale here, where you can see that everybody's coming along pretty much at the same pace, just that they're at different stages. So this is plotting out separately the 0 to 5s, the 6 to 8s, the 9 to 11s, the 12 to 15s, on down. It does have 65 and up very low because those folks tend to be on Medicare, not Medicaid, and this is Medicaid data. Some folks have both double coverage. But the point here is use the code. The reason that I'm showing you this is that for those of you who were using the code in 2016, before it was covered, but you used the code because that's what you were doing, I'm sure those of you who were doing this, you knew this, you showed the insurance companies and the payers, the states, the federal government, you showed them that you were going to use this and do it, and then they started funding it, and then everybody else could take advantage of that as well. So please, 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 let's use the success that we all had in using the 1354 code right from when it was first available and having that help to accelerate the coverage of the code, reimbursement for the code, so that we could all do what makes sense. So please use the code. It worked with 1354, let's have it work with 1355. Generally the same data from a different perspective. So that was the IBM Watson data that looks at about 3.5 million people who are covered by Medicaid. This is PR data. It's just a different view, but this is Medicaid data. Sorry, this is across payers, looking at the same years. There's some nuance with 2019, but this was published at the end of the year in Pediatric Dentistry. And when I first looked at this paper, I thought it was nuts And then I realized that these data are by month. There's an average number by month. So when it says a primary posterior tooth in 2019, it's not saying there were less than 10,000 teeth treated or kids treated or people treated with that code. It was that many per month. So I was initially confused. If you're like me, then note that this figure 4 had per month here. And if you read the fine print, it says per month. So what that means is that, you know, just in this database alone, which is a large database, but this database alone, there's, you know, 6,000 times 12, so about 50,000 people were treated with permanent teeth with silver fluoride in 2019, and that was actually the first half of 2019. So anyway, this is happening. If you look over here to figure 3, upper right, this shows you that, again, pre-COVID, before all the shutdowns, when everybody picked up silver fluoride, we were already at about 30% of pediatric dentists using silver diamine fluoride, and we were already at about 5% of general dentists using it. And then this last one is the most important thing from this paper to me, is this one call out that it gives, is it breaks down the patient by either them or their family's income. And there was this assumption that people had, that people were going around yelling, you know, SDF is going to be, you know, black teeth for black kids, brown teeth for brown kids. And that just hasn't been our experience at all. I have literally put silver diamine fluoride on the teeth of children who are royalty. And their parents sought me out to do that because they didn't want general anesthesia, they didn't want invasive treatment. They learned this, and that's been my experience, is that very wealthy people are just as keen to have this as middle-class folks. And actually the poorest segment of the population seems to be concerned the most about what folks were saying initially about the black teeth for black kids, about the not the color of the skin, but about, you know, the image, about, you know, will stain to the teeth affect their image as they're trying to get out of poverty. That said, this stuff works. It works well, and it's much simpler and easier for the child than all the other tools that we have in our tool belt. And meanwhile, up to 2019, less than 0.12% of all of the claims came from kids who are under the federal poverty level. That's a shame, because I know that many of us are public health or public health focused folks on this call right now. And so that there's a big area to make up there. So some assumptions were wrong, but so wrong that there was a problem. And so is that still going on in 2021? I don't know, but that was going on in 2019. Hopefully that was clear. That said, last bit here, the Oral Health Workforce Center, Research Center, has put together a, you can Google this, you can use this slide, whatever you like, but they have put together a formal presentation of a breakdown by state of where the D1354 coverage is by Medicaid. Those are all the blues here. We've almost completed the circle. And then how silver diamine fluoride relates to hygienists in different forms of practice. Point being here, we've come a very long way in a relatively short time, and we're almost closing the circle. So I would say, you know, mission accomplished. And obviously we're not where we want to be, but we're on our way. The trajectory's there. You know, the rocket has taken off. We're not landing on Mars yet, but it's en route. So now what? If you've ever seen a presentation from me before, you've probably seen this kiddo. Why am I bringing up this kiddo again? This talk is not about arresting caries with silver diamine fluoride. It's not about smart fillings. It's not about Hall crowns that this kiddo, Jaden, is my poster child for. It's about prevention. And it's to highlight the fact that over the, gosh, it's been like 8 years now that I've known Jaden, he has never had a new cavity. So this is a plot of his caries experience, of the teeth with active caries, from before he was 3, when he was getting treated with fillings under general anesthesia and attempting in his chair and et cetera. He kept getting cavities until his first silver fluoride treatment. And initially it was silver nitrate and fluoride varnish, and then we switched to silver diamine fluoride when it became available in the States. And every time he gets a new set of teeth in, a new set of first molars, and now his second molars are in, he gets treated with silver diamine fluoride on those teeth once a year after they erupt. He has never had a new lesion. His diet has not changed. His hygiene hasn't changed. And he has not had a new cavity. So I hope that this frames the point, is that, you know, we've been talking about this kiddo for 6-7 years now, and how silver diamine fluoride saved him from having to go to the general anesthesia yet again, where he might not have lived, which is what the pediatric anesthesiologist was concerned about. But also, he has not had any new cavities, and he's exfoliating all of his primary teeth now, even the posteriors that had the Hall crowns. So that sounds exciting. I think that sounds fun and interesting. But you know, woohoo! Like, prevention doesn't look interesting. You know, it's kind of boring when it all works out. There's no great, you know, look, we went from like looking terrible to looking beautiful. You know, it's like with COVID, you know, when your family is extra careful and you do everything you're supposed to do. So what? Like, success is boring. And that's why I think prevention is not sexy enough for folks to really get after it. You know, you get all dressed up, you do all this stuff, and then what? And so I hope that, like, together we can brainstorm and work together to figure out, all right, like, let's fund D1355, let's get people doing it so that we move on to this next stage of not having people have to have these bad cavities in the first place. Let's get there earlier so we can do something to help folks and keep going upstream. Okay, so that's the call for why and where we've been and where I think we should go. So the code. This is available as a handout. If you just click in your GoToWebinar control panel, in the handouts, there is the 1355 ADA guide to blah, blah, blah. This is available to you. I recommend that you download it. It is also freely available from the American Dental Association, blah, blah, blah. What is this exactly? What does it look like? It says Caries preventive medicament application. We're going to be seeing this term medicament in dentistry more and more for primary prevention or remineralization. Now, I think that there's a lot of weirdness around the term primary prevention. To me, that means someone has never had the disease before, but in this case, it's just at the tooth level. So it also ends up talking about risk, and we'll talk about that a little bit more later, but you can look down here on a high-risk tooth surface. So in a patient with a high-risk tooth surface, so they may already have cavities, they may already have disease, so I would say that's not really primary prevention, but at the tooth level, we are preventing cavities that have not yet happened yet. It also says remineralization. We'll get to that. But again, this is available to you, and we're gonna jump into kind of the depths of what this all means now, how to use this. So 1355 is live. It went live January 1st, 2021. You can use it. It is by tooth. They do want you to use the surface. So you can use more than one surface. It's the same, should be the same payment probably if you do a mesial and distal or just a distal or whatever. The code actually specifies that it may be prompted, the use of this may be prompted by moderate risk or high risk. Now I have my stance on access to care and multiple clinicians being able to help in healthcare. And so being that in most states, hygienists can assess risk, I hope that we can all work together to have this make hygienists be able to use this for prevention and not get in the way of that. It is definitely primary or permanent teeth. More than one tooth the same day is no problem at all. We'll talk about safety a little bit later. That story hasn't changed. You just get to use less silver diamine fluoride when there's no lesion there that's going to soak it up. So it goes even further, even safer. It is okay. It's specifically the ADA sheet that I just showed you that you can download as your handout specifically calls out that you can do a fluoride treatment the same day. No problem there. And it's very sparse, of course, because it's a brand new code, but some coverage has already started. So use the code. If I haven't said use the code, please. Sorry. Okay, so this is really just speaking from my own perspective. I am pitching DentaQuest on this. I'm pitching practices on this. I'm pitching everybody on this. Here's the deal. When you do a sealant, in general, you're on the hook for that tooth for 2 years. And as we'll get to, the evidence suggests that we should be placing silver diamine fluoride for prevention on high-risk surfaces once a year. The evidence is also that silver diamine fluoride once per year prevents about 60% of new lesions. Sealants are about 70%. So sealants supposed to last 2 years, 70%. Silver diamine fluoride supposed to last a year, 60%. So the price should accommodate that difference. That's my suggestion, just personally, no price fixing here. I think one of the big open questions is, what do we do with remineralization? If you have a radiographic lesion and you treat that with silver diamine fluoride, that's 1354. If you have a healthy tooth and you treat that with silver diamine fluoride, that's 1355. So what are we doing with remineralization? We'll get to that a little bit, but I don't have an exact answer for you. I think that's an open question of what that really means. Okay, and I guess what I'd say is that I think it opens for innovations, but I would stay with the 1354 code for now. Okay, there was some FAQ, just really quick here. We can get back to these in the discussion later if you'd like. But after Caries arrest, is reapplication 1354 or 1355? So if you treat a cavitated Caries lesion with silver diamine fluoride, you call that 1354. Any Caries lesion, you treat it with 1354. Retreating it to keep it arrested is 1354. The tooth next door, because that patient's high risk because they had a cavity, the tooth next door that you're using it on is 1355. There shouldn't be any staining if you have a healthy tooth surface. Should be able to clean it off. I put some silver fluoride on my wisdom teeth the other day, and there was a black stain for like a day, and it just disappeared without me, just normally brushing. Is it okay to do 1354 and 1355 on the same day? Yeah, 1355 does not get in the way of any other code, unless it's like the same surface. And should we use 1355 for MIH? There's a lot of folks that say, okay, with this, mild to moderate MIH, I'm not arresting caries. What code should I use? Yeah, use 1355. Sounds great. Most of the time I'm dealing with pretty bad MIH, and so I use 1354. Okay, getting into the weeds here. Any of you who might have seen this paper back in 2016 might know that there was a figure 1 that talked about all the clinical trials on silver diamine fluoride for treating cavities. There was a figure 2 also that talked about preventing cavities with silver diamine fluoride. And none of us have been paying enough attention to it. So now's the time. And this is what this is about. So there's an updated figure, of course, because this was 6 years ago, but yeah. Okay, so that said, now we're going to indications. So 1355. Here are Dr. Jeremy's, the DentaQuest Clinical Innovation 1355 indications. So for a patient with moderate to high caries risk, and there's specificity here in the slides as we go forward, this is the list. We're going to walk through these and I'll show it to you again. I strongly believe that these are all very good money-saving, patient-saving approaches. So we'll walk through them 1 through 6. First one, and I credit Dr. Meenakshi Kerr with this slide. Believe it or not, these teeth were completely arrested with repeated use of silver diamine fluoride and later crowned without any pulpal involvement. That said, why am I showing you this? We're talking about 1355 for prevention. If this little sweetie has these teeth, her sweet little baby should get silver diamine fluoride on his, not her baby, her baby brother, on his front teeth. I do this all the time. I can't tell you how many times a week, and I only practice 1 day a week now. I see kids who have had all D through G extracted, or maybe we managed to save it with silver diamine fluoride, and there comes baby brother doing the same stuff, or baby sister doing the same stuff that they did. So little sibling is going to get the strongest preventive medicine that we have to do this just once a year to prevent caries, to prevent this from happening. So that's one. I don't think you need to keep doing that after the kid turns 4. I think that's a little crazy. So 3 and under to my group. These numbers, of course, are going to vary depending on the dynamics in your population, the ages. Now, back to the kiddo who has this severe lesions on D through G, severe early childhood caries. For that kiddo, when they are 3 to 6, putting silver diamine fluoride in the posterior teeth, maybe 2.5 to 6, you might say, or even earlier in the posterior teeth, that makes a lot of sense to me. If they had D through G extracted, chances are pretty darn good that they're going to have cavities in the back. So let's do this once a year on their back teeth. That's 2. 3, this is what I call the not yet quadrant. You have a kiddo come in, they got one quadrant blown up, they got another quadrant where you're going to use a drill, they got another quadrant, or Hull crowns, they got another quadrant where you're just going to put silver diamine fluoride on. You already have the silver diamine fluoride out. You're going to use your 1354 on that. Maybe you're going to do glass ionomer sealants on the molars. You know, since you're going to have to figure out how to do this stuff anyway, don't leave this one hanging. Don't leave this quadrant hanging. This is what 1355 is for, 100%. Oh, are you guys? Oh, this is where I have to use my mouse. All right. Well, anyway, I've been using my mouse this whole time pointing around. So thanks for bearing with me, everybody. I hope that you can see it now. Yep. Okay, this is what happens when you have a couple screens going. I hope you're all laughing with me. Anyway, the upper left quad here, this is what I call the not yet quadrant. And I would say children in particular, because things develop much more rapidly in children. When you have a not yet quad, that gets the 1355 code. Very simple, very easy. We'll talk about how a little later. Okay, now newly erupted molars. So here you're seeing partially erupted first molars, partially erupted third molars. Just so happens that those partially erupted third molars have already been treated with silver diamine fluoride once a year for a while. So if there's moderate to high caries risk, this person would get it. You see some restorations where they placed in the last couple of years. Very simple to assess caries risk. You look at this tooth, you're thinking probably at least moderate risk. Straightforward. Now in this kiddo, if there's no caries history, low risk, they don't need sealants, they don't need anything. If you really want to do something because you feel like that's what you should be doing, these really healthy looking teeth, very simple, very quick, a 20th of the time and expense to just touch that with silver diamine fluoride and move on. So this is a good indication. So newly erupted molars, I would say 3 times when they first are coming in like this, a year later and a year later. Number 5, proximal posteriors in high-risk teens. So when a teenager comes in with that 2-liter Mountain Dew, of course, what they're actually drinking changes year by year. But when they're coming in with, something that's full of sugar, you can bet, you already know what you're going to see in the radiographs. If you don't see it yet, you will. So this is really the opportunity for those kids. So this is, a stratification based on what I have seen in my career of what typically happens, of the incidence of new lesions, of what typically happens. It may be that in your clinic or clinic system or population, it's totally different. And you would say, oh, no, Jeremy, this is what happens with my population. Well, then that, figure out when that starts. That's when you would target it. But so this is, to be taken with relevance to your population. And so, of course, as well, there's exposed root surfaces in high-risk elders. And I kind of go back and forth on elders because there's a lot of folks that have recession that aren't so old like me. I don't have too bad a recession, but there are people who are my age who have. Anyway, but obviously the older we are, the more likely it is that we have caries, the more likely it is that we have xerostomia from medications or physiology. And so exposed root surfaces in high caries risk elders we should be able to prevent what you see here in these pictures. There is clinical trial evidence to support that. I will show you that very soon. So those are the 6 DentaQuest clinical innovation indications for D1355, specifically in a moderate to high caries risk patient. The ADA code calls that out. Cool. Now on to the medicaments. So the ADA wording specifically calls out these top 4, which we'll march through pretty quickly. And I just want to say that there's this potential for these other 2 to be considered. I hope that you see this cross out, that in case I skip over it or if I go quickly on that, I want you to know, I think there's strong evidence against using that. And with the ADA recommendation against it, I don't think that it would fare well if you tried to use it. Long story short. So here's the medicaments. We're going to go through them, spend most of our time on silver diamine fluoride, surprise, surprise, but we will hit the others also. So if you have been hiding underneath a rock, then you need to know what silver diamine fluoride is made of. This is what it's made of. So please note it's 5% fluoride, which is over twice the concentration of a fluoride varnish. So it's a very strong fluoride. Fluoride and most things work by a diffusion gradient. So having it be twice as high concentration means that you actually, depending on what's going on the surface, you can get a cubed amount of material of fluoride into an area, into an absorption. I've had this slide for a very long time. And I've always said prevents caries, and we've always kind of glossed over it, but now we have a code, so now we're really going to do it. So don't forget, it arrests, but it also prevents. Again, how does it work? This slide's been around a long time. It remineralizes, sure, but it also prevents demineralization. It prevents bacterial growth. And so plenty of times there's, we've done these micro CTs that you guys have seen, and I'll show that in a little bit. Never mind, I'll pause on that. Okay, how do you use it? So I get this question all the time. Okay, I use silver diamine fluoride all the time for caries lesions. I like to use it on cavitated caries lesions that are cleansable, or as a first step for a smart filling or a Hall crown or whatever. How do I use it for prevention? So first thing, keep it simple. All that you need to do is wet the high-risk surface with silver diamine fluoride. Other than that, nothing changes. That should simplify your protocol, not make it more complicated. That should decrease the total amount of material that you use, not increase it. So same cotton isolation. If you're one of these folks that really likes to use toothpaste on the tongue and underneath the nose, I do that sometimes. I think it's amazing. Jeanette McLean is a genius. So many things she's come up with. Vaseline on the lips, all this stuff. Yes, you do the same stuff. So you get the tooth as dry as you reasonably can. And of course, maybe not during COVID-19, or maybe everybody's vaccinated and you can, or whatever, but maybe not. But you dry it as well as you reasonably can. And of course, the great Dr. Steve Duffin just told me the other day, he said, I cut out like a 2x2 of the patient bib, and I put the absorption side down and put the paper side down, and I sort of cover over the air water syringe, and I just do short little pulses of air on the surface, and I'm able to get it desiccated like I used to with the long dry thing. And so innovation, but bottom line, get it as dry as you reasonably can, touch it with silver diamine fluoride, you'll see that blue tint, go wherever you need it, and then protect the reaction for a minute. So what does that mean for me? That means I look at the quadrant that I just applied it to for about 10 seconds. I take a 2x2, dab up the excess, and I cover it with a Vaseline or a fluoride varnish, depending on how anti-fluoride the family that I'm dealing with is. My clinical work is in the middle of like anti-vax, anti-fluoride country. I have yet to meet a parent who I couldn't convince to use silver diamine fluoride, but there's a lot of folks that don't like the fluoride varnish, which does have about 6 times as much fluoride in it. So we use Vaseline in those cases, or any petroleum jelly or cocoa butter or whatever you like. As I said, so anybody's welcome to use all these slides. Fluoride varnish, it takes 6 drops of silver diamine fluoride to have as much fluoride as there is in fluoride varnish. So there's a really small amount in silver diamine fluoride. Thank you to Dr. Yasmin Crystal for doing the hard work of figuring out exactly how big a drop is and all that stuff so that we can properly do this calculation. What does that translate to in terms of risk of fluoride uptake into the body? There's been 2 different papers published, and overall, these lines look pretty straight to me. I have done pharmacokinetics. I certainly know how to do math and trends, and overall, I'm not seeing an increase in fluoride in the bloodstream in these 2 graphs. If you are, great, and clearly it's not that much, if it is any. So that is impressive to me. You know what I need to say? That is with extremely careful use of silver diamine fluoride, using like the techniques like I described. You have to soak up the excess, you're not slathering it all over the place, etc. Okay, now back to mechanisms. Sorry for this being slightly out of order. This is a slide of a very sweet kiddo's tooth. I'd love to tell you that whole long story, but Dr. John Pacella or Dr. Steve Duffin can tell you it. I recommend you going on to mmclibrary.com, medical management of caries library.com, to see the interview of Christina and Claire, the mother and daughter who are responsible for this tooth, along with Dr. Pacella and Duffin, who are responsible for this tooth. But long story short, the reason that I'm showing you this is that there was a caries lesion towards the incisal, the incisal third or half of this anterior, I think this was tooth F. And Steve Duffin arrested the lesion with silver diamine fluoride, and John Fricella covered it with some beautiful glass ionomer. And after the tooth exfoliated, we chipped it and scanned it. And what you can see is there's this black area here, but all of this fuchsia area in the really, in the micro CT, all this fuchsia is extremely dense enamel. Do you know what extremely dense enamel is? It's fluoroapatite. So there's a thin layer of fluoroapatite, which highlights the importance of the fluoride and the preventive factor in silver diamine fluoride. After the first silver diamine fluoride treatment, this kiddo who had multiple lesions in D through G never got a new cavity. Surprise, surprise, that's what happens. Another tooth from Dr. Duffin, where these little red dots, that's all the silver that was in there. So again, this shows that you can have, early lesions that you don't even see with the naked eye that can pick up silver and stay in the tooth, preventing caries in the most high-risk areas with one application early on, and this tooth exfoliated like this. So just to show 2, detailed examples. Okay, now we're going to go into the evidence. Again, I'm going to go through this fairly quickly, just in the interest of time, and just highlight the take homes. I hope that you guys use this. We published this a couple years ago now. Just an update. As far as I know, there's been no new prevention trials published, but there have been some started since we published this paper. So if you haven't seen one of these talks before, how I set this up is that each different panel is a different clinical trial. It has the details of the trial at right. The first author, the year it was published, the number of people in the trial. Yes, that is 849 5 to 8-year-olds. This happens to be a split mouth study. This one was 40% silver fluoride, not silver diamine fluoride, but 6 of one, half a dozen the other. Maybe it's 7 of one, half a dozen the other. I don't know. Overall, pretty similar, etc. All of these are, all the bars that you see are relative to a control group. Now the control group has a certain number of cavities that's defined at right here. So the control group had 12 new cavities here, 9 new cavities here, etc. These are not our nice little private practice kids that get an enamel lesion every now and then. Down here they are. All of the bars, I've tried to define the periodicity of the silver diamine fluoride. And this is impressive to me that this is once, and here we go. So overall, so this is the meta-analysis across time, and I would say that there is no trend based on the statistical analysis of the change in the preventive fraction, how many cavities were prevented relative to the control group. I think there is no trend over time, and I would say that we have about 60% prevented fraction with say once per year application. So we're going to go into that detail. So these two studies were the first two modern randomized clinical trials on silver diamine fluoride. They were focused on treatment. As Dr. Yasmi Crystal pointed out to me, which I misinterpreted to begin with, thank you. This is about anterior teeth, and they did treat all the anterior teeth with silver diamine fluoride. And so yes, it arrested lesions, but it also prevented lesions. The gray and the black were prevented lesions with silver diamine fluoride that were more so, up in the 60%, compared to normal fluoride varnish 4 times a year. So let me get that again. Way more prevented cavities with silver diamine fluoride once per year compared to fluoride varnish 4 times per year. We'll get back to that. And then this study, not a perfect study. The control group was not really a randomized control group. These kids were randomized whether they got once or twice per year, and there was no difference over time between the once or twice per year over the year. So once per year may be enough. This is very early data. Sealants, so the green here are sealants. One is with resin, one's with glass ionomer. You know, probably need more studies with both of those different materials, but it does look like sealants are more effective. If you look across studies, again, we have about 70% prevention with sealants and about 60% prevention with silver diamine fluoride. That said, both of these studies looked at cost effectiveness, and others have as well, and they assessed silver diamine fluoride as 20 times more cost effective than fluoride than the sealant. And then there's these little studies. I don't know. These are older studies from Japan from the 70s and 80s. Certainly, there's this one study that showed no difference in 26 kids. I don't know what to say about these. So that was a joke. I hope you can appreciate the joke. These studies are in elders, older adults, and this is also relative to a randomized control group, a placebo in each of these cases. And so in particular, this middle group is silver diamine fluoride once per year compared to fluoride varnish 4 times per year, or chlorhexidine thymol, the Cervatec, 4 times per year. So you've seen the story before, you're seeing it again. Silver diamine fluoride once per year prevents more cavities than fluoride varnish 4 times per year. That said, I do want to highlight, since Cervatec, it's the only chlorhexidine thymol product that I know of, was called out in the 1355 language. This is one of the 2 studies or 3 studies that shows prevention relative to a control group. Every single study that has looked at chlorhexidine has shown no prevention with chlorhexidine. The studies that have looked at the chlorhexidine thymol product have shown prevention. So probably chlorhexidine does not prevent cavities in humans, but probably does. But thymol probably does. So anyway, so how do we turn this into a protocol? So for mild caries risk, don't put silver diamine fluoride on them. For moderate caries risk, once per year. For high caries risk, once per year. Sounded like a broken record. Okay, so silver diamine fluoride, yes, that makes sense. Silver nitrate, I don't know where they got that from. There's no clinical trials with silver nitrate only for prevention that I know of. I don't know where that came from. I wouldn't focus on that. Chlorhexidine thymol, we have now gone over. Yes, that makes sense. Marginal, but it seems to work. Iodine, we're going to quickly go through this. I hope to do another presentation on iodine in the coming months for reasons that will become clear soon. There's a lot of data here. For those people that like data, here it is. I did the meta-analysis. These are all the clinical trials or comparative cohort studies on using povidone iodine, just normal, over-the-counter, easy to access. Here's a bottle. Povidone iodine with a Q-tip, just saturating one end. We're going to be publishing papers on this very soon. It prevents caries remarkably well. What I want to highlight here is that this is at the patient level. So if you know me, you know I don't put things in all capital letters very often, but I put this in all capital letters. Fluoride varnish, the meta-analyses on fluoride varnish do not show any effect at the patient level. There's trends, but nothing significant. This is at the patient level. We're preventing 38% of people in high-risk groups from getting cavities, just with iodine, Q-tip, shot glass. I mean, you can use something nicer than shot glass if you want. Very simple. Long story short, 2 to 4 times per year. It seems to be about 50% less cavities if you're counting teeth, but we can get into those details a different time. Why aren't people doing this? Well, there's no dental product. You know, dentists want the dental product, and people follow what the dentists do. So, if you could please, we're going to start the video now about iodine. See if I can do this, make this happen. We have a little music. All right. This is just going to take a second. We're geeking out. It's fun. Wow. I don't know what happened. Hey. All right. That was fun. Thanks for entertaining, letting letting me be entertained. So yeah, so Elevate and I have been working together to try to get that out. That's a very precisely dosed amount of iodine that is very safe to be used, certainly more than once every other month at any age. Long story short, so one of the concerns is dosage. You know, really, you can just take one end of a Q-tip, saturate it once, don't re-dip, and you're fine. But you know, if you want to be super safe, we got this. And I'm really excited about it. It's really easy to brush, just a tiny amount on. Again, papers coming out with all this data. So now, iodine prevents cavities. That's great. CPP, ACP, we're not going to go into the details, but if you need the talking points ever, the ADA has recommended against this. I think the ADA maybe recommended against like hand over mouth technique, and CPP, ACP, MI paste. Meanwhile, that product is being sold like gangbusters. So just speaking on behalf of myself only, that stuff should not be considered for the 1355 code. Very briefly, I've become more and more interested in this product called Curodont Repair Fluoride Plus. It's a peptide. If you want to really be bored, you can go read my PhD thesis and see that it was all about peptides that make enamel. So I got really excited about this peptide that remakes enamel. There have been 6 randomized clinical trials. Almost all of them were published in the last couple of years. 2 of them were really properly conducted. The others, there were good split mouth studies, and you know, overall not a ton of patients in them, but together it has a consistent arrest of caries for enamel lesions. So I think this should be considered as well. We have launched a study comparing all these treatments for early caries lesions, like 1355. So hopefully you will hear back from us as that goes forward. So we've talked about the medicaments. We've talked about where 1354 has taken us. Now we've landed with 1355. The material is there for you. The second handout is these slides, just as a PDF. And this last slide I'm going to show you that we're going to do the Q&A with. You will see a website, and that website, you can go there and you can get the PowerPoint slides. Again, please just use them. If you want to credit me, great, but just we need to get this moving forward. So we're all in this for is for improvement. So it's not medicament specific. I think these 4 here that it lists make a lot of sense. Consider Curodont, makes sense too. It's a cool new trick in our bag. And with that, I thank you so much for your time. Please feel free to contact me. Again, if you're an innovator, if you're coming up with new stuff, give me a call because that's my job now. And with that, we'll take some questions.
All right, thank you very much, Dr. Horst. We really appreciate your presentation here. We do have a good collection of questions. If you look in the questions bar, you will see a link where you can download Dr. Horst's slides and handout. And as you mentioned, feel free to use those and share them as you need to. So one of the first questions that came in, Dr. Horst, is how would you verbally communicate this to a patient and recommend SDF treatment as a preventive product?
Yeah, thank you. And I can't see the questions myself, so I'm going to rely on you, Steve. So it's we have a new medicine that prevents cavities better than anything we've ever seen before. We see that you have a high risk of cavities. This prevents about 6 out of 10 cavities per person. Would you like to learn more? And then whenever we pull out something that stains as much as silver fluoride does, I'd show some pictures. I would invite everybody to start taking more pictures of little stains, stains at the leaking margins of restorations, and so hopefully we can have some of those in the open, out there for people to use, and we can create some of those resources. But that's what I would say, is that we see their high caries risk, and are you interested in this?
Okay, very good. Appreciate that. The next question is along the lines of stains that you just mentioned. You mentioned that you applied it to your wisdom teeth and saw some temporary staining. Does that need to be cleaned off, or does it fade on its own? And then a second follow-up question to that is there significant staining on MIH?
So the temporary stain subsides on its own. Yeah, exactly what I said. I put it on my tooth, the stain showed up for 2 days, and it just naturally disappeared with normal brushing and eating. So I don't think you need to like polish it off or anything like that. But if you have porous enamel or porous dentin, that's going to have normal caries arrest stain. So MIH definitely stains. If you have little incidental, almost like the white spots on the front teeth, if the surface is intact, it's not going to stain. But if you have porous material, it's going to stain. And there's a lot of beautiful opaque materials that can cover it, etc.
Okay, thank you very much. The next couple of questions are actually going to revolve around some sealant type questions. If you're using silver diamine fluoride on a newly erupted 6 and 12-year molar, is it most appropriate to use a sealant code or the D1355 code if it's in place of sealant?
Yeah, 1355 code. Thank you. That's perfect. Yeah, absolutely. That should be 1355. If you're not placing a sealant, shouldn't call it a sealant. So that's where you're going to use 1355. Honestly, candidly, what I would do is I would use the D1355 code, and I would be billing a 1208 because I'm probably going to put that on other teeth as well as a fluoride treatment. So okay. That's what we have been doing. It gets a little tricky now that we have this 1355. Do you bill people out of pocket? It's sort of a practice philosophy issue. But I would not bill sealant unless you place a sealant.
Okay, very good. Thank you. The next question is still on the sealant topic. What would be the determining factor in choosing whether a sealant should be placed or SDF should be placed for permanent molars? And if you do choose, just a follow-up to that, if you do choose SDF, should a sealant be placed at a later date?
There's a practicality question here. If you're in a private practice and you're serving 3,000 people or whatever the size of your practice is, 1,300 people, whatever it is, and your focus is really to optimize the health of those individuals, and you have somebody that really has high caries risk, put silver diamine fluoride on first, it's 1355, and then later go back and place a sealant. Sure, absolutely. Belt and suspenders. If you're trying to take care of the whole country or the whole world or the whole state or your whole town, it doesn't make a whole lot of sense to go around spending 20 times the money and time to place all these sealants when you can get almost as good with the stroke of a brush. So if you're thinking about if you're thinking from being a payer, if you're thinking from a real public health standpoint, if you're really trying to do some good, we have a way to do that good. And so obviously the payers should be jumping on this train now that there's a billing code to do so. So it's kind of that's the question. I don't think we have enough hands to place sealants on every person in the country or world that should get them. So I do think we're getting somewhere by having the stroke of a brush instead.
Very good, thank you. And a couple more questions on the practical side of the application before we get into more of the technical things. There are lots of questions of, should it be a thin coating? Should they slather the teeth? How many teeth at a time can I apply? For how long? So could you elaborate on that a little bit for us, please?
Totally, yeah. So I mean, so I do, I tried to highlight in the slides that, we're kind of going by sextant, and you're almost never, not almost never, but you're usually not going to apply to every sextant. Maybe you can do the 4 posterior, what we call quadrants, but really they're sextants. So I do that 2 posterior areas at a time. And so I will isolate with cotton, cotton roll on the lower lingual, dry shield on the cheek, and maybe another 2x2 to keep the tongue out of the way, depending on the patient. Dry the area as best I can, upper and lower, and put the silver diamine fluoride on the lower, put the silver diamine fluoride on the upper, again, the high risk surfaces. So if it's a teenager, maybe it'll look like the proximal areas. And so I literally just let it go from dry to wet. And by the time I go from the lower to the upper and I'm coming back to the lower, if that's 5 seconds, if that's 10 seconds, maybe I'll count to 3 and dab the excess, cover it. Again, if I'm in this private practice model or even a public health model where I have a limited number of patients, I'm not in a rush, can I let it soak in for a minute? You bet. If I have somebody that doesn't like varnish or Vaseline in their mouth, who does? And they're willing to sit there for 5 minutes with their mouth open and a little, saliva excavator in there, would that help? Sure, give it a try. But a thin amount, just enough to wet it, allow it to soak in. We know it absorbs at least into the surface very quickly. In these situations, it does not have to absorb deep. So it's pretty quick, remove the excess, cover it up.
Very good, thank you. That does make sense, appreciate that. Next questions, this is kind of along the same lines, more of a practical question. Is there a reasonable charge per tooth, or is there a ballpark that you feel is appropriate?
Yeah, so again, I'm not going to get into dollar amount, just the more I learn, the more I see that we're really all in different, numbers are very different from geographic area to geographic area. But I do feel comfortable saying 30 to 40% of a sealant, and that payers should cover that annually. So whatever you're charging for a sealant should be about that amount. I think per tooth, that should be lower than fluoride varnish because you're going to be doing more than one tooth. So I think per that visit, it should amount to more than you would get for fluoride varnish. I think that's about all I can get without the Federal Trade Communication folks coming after me.
Perfect. Next question, I think you had this in your slides as well, but how does using silver diamine fluoride preventively compare to the preventive value of a fluoride varnish application?
Yeah, so again, I mean, fluoride varnish is great. It's gotten us a long way, but we have a trial in children showing superiority of once per year silver fluoride compared to 4 times per year fluoride varnish. And guess what? We have a trial in older adults, root surfaces, showing superiority of once per year silver fluoride to 4 times per year fluoride varnish. Now, in these older adults, in this study, it looks like the fluoride varnish is starting to catch up. That's great, but it took 3 years to get there. And what happened in the meantime? And meanwhile, it's just once per year versus 4 times per year. I know what I would want. I know what I want to do for my, the older adults in my life.
Okay, yeah. Very good. And the last one's a pretty technical question. How does silver diamine fluoride adhere to the tooth when there's no lesion present?
That's a good question. So there's been some work on that. I'm not stoked enough on the work to show you guys anything, but I'm going to go back to these two. So first, silver fluoride is it's a dual therapy. It has the silver and the fluoride. So if there is a lesion there, the silver will work against it. Meanwhile, you have the fluoride. How does fluoride work? If you have no porosity, how does the fluoride get in there? Well, what we know is that there's very small microgaps in the crystalline structure of enamel in the interprismatic space. where things like fluoride can absorb. Turns out it seems like it's hard to get these data. Just the instruments don't work very well in this realm. But it seems like the silver goes in the same space. So it seems like we're getting fluoroapatite. It seems like we're getting in the interprismatic spaces some silver getting in there as well, which helps to prevent the bacterial growth. So sort of, if I can throw this out there, there is emerging evidence of control of gingival inflammation. There is one randomized controlled trial that shows short-term effect on gingival inflammation. And there is some very strong patient cases where we have these, in particular, the stories are profound, the pictures are profound. I'm not showing them, Dr. Duffin has them. There's a number of folks that have them. A lot of the hygienists have them, where they put silver diamine fluoride for some caries lesion and the gingiva heals up. How is that happening? Does the silver fluoride stay in the gingiva? It's probably something to do with the silver staying in the porous parts of the enamel without staining. Maybe it goes into the cementum or the periodontium somehow, but it reduces the bacterial buildup. So we're seeing an anti-plaque mechanism somehow that seems to affect the periodontium and the plaque on the tooth itself. Not really well understood yet. We do know, as you know, I've done a lot of the work trying to figure out the changes to the bacteria. It doesn't seem to shift what bacteria are there. It just seems to reduce the bacteria in general. So I would say that trying to put together all the evidence that's out there, it seems like there's a little bit of silver, just enough that goes in and it's on the surface interprismatic space, and that seems to reduce the amount of bacteria that's able to build up, certainly on dentin, but also it seems like on enamel. That's my best understanding of what's going on.
I think it's a great explanation. Very much appreciate that. And thank you very much for a great presentation. For all of our attendees, this recorded webinar will soon be posted on elevateoralcare.com/elevatingcare, so you can watch it after it's recorded. The handouts are in the handouts tab of your GoToMeeting control panel on the right-hand side of your screen. And additionally, in the questions panel, you should be able to see a link where you're able to download Dr. Horst's slides and his handout as well for your own use. We thank you all for joining us this evening. Your CE certificate will be sent out within an hour to 2 hours after this presentation concludes. And again, from all of us here at Elevate Oral Care, thank you very much, Dr. Jeremy Horst, for presenting with us here this evening. And thank you all for attending.
Thank you very much, Steve, Elevate. And again, thank you everybody for the honor of your time. Go use the code.